one or two pieces of new research that you've come across recently?
Yeah. So the one that I really like at the moment, purely just because I've been rehabbing an athlete that's had this particular pathology, there's a paper that's come out of Leinster Rugby by Fergal Karen. And basically what it is saying is that hamstring injuries can occur for a number of different reasons. So I think historically we were always taught that you can only tear your hamstring if you run really, really fast or if you overstretch it. But some of the research that's coming out now is saying that you can actually tear it a number of different ways. So you can do it tackling, sprinting, accelerating, decelerating. It can be just sort of like an insidious onset sort of post run. So there's actually, you can't just rely on the subjective findings of, oh, what did you do? Were you running fast? To be able to identify that. I think there's also stuff coming out from them in regards to biceps T-junction injuries as well. So that's really, really fascinating. I think that was first identified. I'm not sure if you've heard much about the T-junction injuries. Has that kind of hit Australia yet? Not so much.
Not sure about Australia, but I've definitely never heard of that.
Okay, so basically, so T-junction injuries. So essentially, in 2017, there was actually a research done by Entwistle, I think his name is, and that was actually done out of Melbourne. And it was basically they imaged all these AFL players. I think it was like 50. There wasn't a massive cohort, players with distal hamstring injuries, and they found quite a high percentage of those players had actually damage to their T-junction, their distal biceps femoris region. So basically, what this injury is where the long head and the short head, the biceps, they separate basically. So you have this distal hamstring injury, and you disrupt the sort of the membrane between it that kind of keeps them working synchronously. Sure.
Yes.
Synchro, yeah, together.
Yeah.
And they think that there's a high risk of re-injury if you have damage to this particular region. So yeah, the research coming out of there is basically saying we're missing a few T-junction injuries, and this is the reason why distal hamstring injuries often like result in re-injury within the 3 months post return to rugby, if that makes sense, or AFL or whatever sport it is. So yeah, it's been kind of hitting the papers out here basically in terms of, okay, cool. So if there is this sort of pathology that we're missing, like what can we do about it? So Leinster Rugby have been doing a bit of stuff about, well, what can we be doing to kind of rehabilitate them? And they've kind of fallen down the pathway of we just need to respect the healing phase, essentially. So take a little bit longer in the early loading phase. And then basically you'd rehabilitate it like a normal hamstring, but then you'd also take into account some other factors. So they're saying that ipsilateral trunk flexion could have a high correlation with this injury as well. So making sure that your program is quite holistic. So not just doing isolated hamstring rehab, but looking at the bigger picture. So looking at some sort of anti-rotational type of exercises as well. There's also then papers coming out by Professor Haddad over here. So it came out in 2020 saying that surgical management is the best approach for these injuries. That's still quite controversial because there's quite a lot of physiotherapists coming out saying that they believe that they can actually manage these conservatively and do it quite well, given providing that we respect that early healing phase. But yeah, so I've actually just had a player myself that I've rehabilitated who underwent this surgery by Professor Haddad. So his research is coming out saying that you can get the players back to full return to sport within 11, 12 weeks, plus or minus, I think, 3.9 or something like that. So that's quite interesting, and a higher patient satisfaction rate as well. So there's not really been any good quality evidence yet to be able to compare surgical versus conservative management because it's still quite an early concept. And it was interesting when the Wallabies were over here recently, I caught up with Sharon Flahive, who's the Wallabies doctor, and we were discussing this concept. And she was a little bit surprised that, that surgical management has been happening for this injury. She was quite confident that we could manage this conservatively. But again, like we did discuss that it is too early to draw conclusions either way. But it's interesting that the perspective, people kind of sit on the fence whether or not conservative is the best approach, surgery is the best approach. So yeah, we basically went down the surgical pathway for this athlete purely because he kept re-injuring the same area. So we were evident there was something we were missing. So yeah, that's particularly why we went down that pathway. But we've got a player at the moment who we're actually rehabilitating conservatively for a similar pathology, but this is his first ever hamstring tear. So just taking clinical consideration into account with this kind of stuff. We did definitely seek professional advice with this, but yeah, if that makes sense. So conservative versus surgical still, yeah.
So you mentioned when rehabbing T-junctions conservatively, the main thing really is to respect the early load integration a bit more. How does that kind of compare to a normal like a hamstring injury or another hamstring injury? What do the timelines look like? Yeah, what are the differences?
Yeah, so you could still, so the one that we've got at the moment, so typically you'd spend the first 2 to 3 weeks unloading that sort of distal hamstring region. So allowing the scar tissue to form to develop a really, really strong foundation. So you'd still do some isometric loading, so some really low level isometric loading, but you'd mainly focus on rehabilitating the more proximal hamstring musculature.
Mm.
You'd also then look at doing, obviously use that time to work on some of your hip capacity, your trunk stuff. So deloading around the knee, but then still maintaining some of the load around the more proximal structures so that when they are ready to return to run, you are able to kind of, go for it essentially. But then once they kind of pass that sort of 3-week phase, you can start to then reintroduce some of your heavier isometrics. So the way that we typically do it is, so your resisted prone isometrics to start with, and then you can start to work through a little bit more sort of hip flexion angles. So your heavy isometric focus, and then it's the same as a hamstring. So you kind of work with your concentric, eccentric sort of stuff would be the next thing that you would introduce. You just kind of stay away from sort of end range positions to start with. You build them into that over the coming weeks. You could also then, before you get them into your high stage running, it's the same sort of test that you would do for your normal hamstring. So you'd look at your Nordics, you'd have a look at we do like an isometric long lever bridge, and we do sort of some like prone isometric testing as well in like 30 degrees and 90 degrees as well. So yeah, it's just that you'd spend those first 2 to 3 weeks just kind of not providing that much load to the distal hamstring. So just isometric load and then work around it basically.
Yeah, gotcha. Okay. And so how do you identify, or can you identify clinically, uh, when it is a T-junction injury?
The research says no. So there are some clinicians that believe you can actually feel a palpable gap between the long and the short head of the biceps, but basically the only way that you can tell if it's going to be a tear is through MRI imaging and just clinical suspicion. So they're typically the only two things that will be able to accurately diagnose a biceps T-junction injury.
Clinical suspicion, what exactly are you suspicious of?
Basically just the location of where the pain is. So yeah. So if you've got an injury that's around sort of that distal biceps femoris area, tended to palpate around that area and it just seems a bit odd, then you definitely be referring them. We're quite lucky, I guess, in the environment that we work in that we can just send all of our boys for images of their hamstrings, and we typically will. Anyone that injures their hamstring will get a scan. Unless it's just DOMS and it's very low grade stuff. And you obviously take a few things into account, but 90% of our hamstring injuries that we get will be scanned.
Yeah. Okay. And what's I'm blanking on that word, but like how often does a T-junction injury happen? The prevalence.
Yeah. I think it's still too early to tell, to be honest. I think it's because it's such a new concept. So it was only really first identified in 2017, and then the Professor Haddad stuff was only coming out in 2020. I think it's something that's been happening for quite a long time that we've kind of maybe missed a little bit. So it's quite interesting reflecting back on some of our previous hamstrings. I think one that I was reflecting on personally was I had a player 2 or 3 years ago who had a distal biceps femoris hamstring injury during his rehabilitation, then ended up injuring his calf, and then during his calf rehabilitation ends up re-injuring his hamstring. And I think in this sort of sense, so again, with the research saying that you're more likely to re-injure your distal hamstring the first 3 months after return. So kind of reflecting back on it, I was like, is this a T-junction injury that we missed? Did we load it too early? Did we maybe not spend enough time in that protective phase and give this athlete the most optimal ability to be able to recover? And I think in reflection, yes. So it's interesting to see how many other practitioners have kind of had this experience now that this research is coming out, being like, oh, yeah, I think I might have had one of those in the past that I've missed. It's hard to say because we weren't imaging all these players, but I think now that people or radiologists are specifically looking for it, I think we'll probably pick up a lot more than initially we had because they're being educated that this is this new thing that's coming through.
Okay. And I'm pretty sure uni has taught us that the most common hamstring injury is your biceps femoris. But the specificity of location of the biceps femoris hasn't exactly been mentioned.
Is that we may need to modify. So, for example, if their Nordic scores are down, then we might go, oh, you know what, today's not the day to sprint. We might then go, okay, so you're a back, you've historically had quite a lot of hamstring injuries. You know what, maybe we'll keep you off feet today. If you're a forward or say you're a prop, you don't really sprint. So you might only do 500 or 600 meters of running in a training session and it's more power-based stuff. We'd typically be like, okay, cool. We've recognized that. That's great. You're probably still fine to do a units training session, but maybe when we get to the rugby elements, we will modify some stuff depending on what the drills are. So that's where it's important to be able to communicate with the coaches and have a plan in place. So, well, what does training actually entail today? Does it entail any sort of high-speed running drills? If it does, we may need to modify some of the guys. Is that all right? And most of the time they'll be like, yeah, of course, not a problem at all. You do what you think's best. But it's quite handy to actually have data to back up what you're saying as well. Because if you go up to a coach and you're like, nah, they're just not feeling it today, I don't think they should train. And the coach will, well, why? Whereas if you go up to the coach and go, they're not really feeling great today. Their scores are down by 20%. We probably think that's not a good idea for them to do any speed stuff at training today. They'll be like, oh, okay, no problem.
Yeah.
So it is quite interesting because sometimes it could be the fact of, the players couldn't be asked. And that's sometimes the case. Like they've had a really big game. They come in and they're like, I just don't want to give a maximal eccentric contraction today. I'm just going to do this and hope that no one picks up on it. So it's quite important to try to keep athletes motivated to be able to perform the test to the best of their ability each time that they do it, just so that we can get a really solid sort of database for them so that we can accurately identify when they actually are at risk and when they just can't be asked.
Yeah. Okay.
Yeah. So we'll do the Nordic. For our hamstring, we'll also do a long lever bridge. So that's basically almost like an isometric hip thrust. So we'll get a really, really heavy bar across their hips. They'll have their shoulders on a small box, and then they'll have the feet on the force plates. And what they'll do is maximal isometric contraction of left and right leg, and see what their force is like again. So we hold them accountable to 0.6 times their body weight for that particular test. So there are two main hamstring tests that we do too. In regards to our calf, so I think the calf we probably see a lot more calf injuries than we do with our hamstring. I'm not sure whether it's because there's a lot more hamstring research going on at the moment. So we know that if you sprint, you kind of want to be hitting greater than 90% velocity every 10 days or within every 10 days for hamstring conditioning, because that's when you get the most amount of force through your hamstrings is at that high speed. So as a conditioning stimulus, we want to be running them fast. We also know that we've got Nordics as quite a good test to be able to tell us whether athletes are at risk or not. So, and there's always like acute chronic workload ranges, all this other stuff coming out about soft tissues. But I feel like the hamstring research is a lot more thorough compared to some of the calf stuff that's out. So the calf is quite an interesting one because it is one of those injuries that often occur in rugby, and you think about the force that's going through the calf. So through some of your EMG studies, you actually see that whether you run slow or whether you run fast, your calf is basically under the same amount of force regardless. So whereas your hammy, if you run pretty slow, you're not really activating your hammy, so you can commence your running pretty early. So yeah, back to your calf stuff. There is some research coming out. Again, I think through some of the Irish rugby system, there was a paper that came out that involved some different clubs as well about what percentage of body weight is adequate to be able to hold players accountable to. So we've got this new system. I don't know whether you've seen, have you heard anything about the force frame setup? It's almost like the grain bar sort of thing.
Sort of. It came across a little bit of it, yeah.
Yeah, so a lot of clubs are now investing in this force frame. So you can do some of your calf testing on that, neck testing, shoulder testing. There's a lot of stuff that I'll delve into in a moment. But there's some research that's come out from some of the premiership clubs as well, saying that I think the forwards need to be held accountable to, I think it was 1.75 times body weight, and the backs were 2 times body weight. But their setup was slightly different. So they were using more of a strap setup across their knee. So they basically had their foot on a plate, and then they had this big strap that was kind of keeping them down. The force frame stuff that's coming out, because force frame is still relatively new to some of these professional clubs, the data is not as available yet. But there has been some stuff. I think David Breen put out some stuff through Munster Rugby. I think he was at the time, and they found that through the force frame testing, you see the plan flexion scores were, I think, a little bit lower. I think the forwards were 0.6 off memory, 1.6, sorry, and the backs were 1.8, but I'd have to double check that. But they were slightly different. So basically, in summary, even though there's a lot of data coming out about what percentage of body weight you should hold your players accountable to, I think it's quite important to think about how you are measuring this and what positions that you're measuring them in. Because historically, we've just been doing it on a force plate with a big bar across their knee, and we've been holding everybody accountable to 1.5 times their body weight. But this year, what we're going to do is that same test with the bar, but we're also going to do it set up half kneeling in the force frame and just see how that data correlates. And then we're going to compare, obviously, the data that we're getting to some of the other clubs and see kind of where our athletes around about sit. So yes, we'll do a seated plantar flexion test. We'll do a kneeling plantar flexion test. We're also going to introduce for the first time a 5RM calf test, just a seated calf test. So we're just trying to play around with how we're going to standardize that, because obviously you need to take into account, I guess, ankle range of motion. We set this to a metronome as well, probably. We'll weight up. So basically we'll use it as part of their gym program rather than being like, do 5RM right now. I think we'll kind of build towards a 5RM over a couple of weeks and kind of see where they get. And we'll also do a calf capacity test where basically they've got their foot on a little gym block. There's 2 gym blocks set either side with a piece of elastic across. They have to, the front of the forefoot will be on one block, and then they'll basically they'll go down into full dorsiflexion, so the heel touches the ground. And then when they go up into a calf raise, they basically have to come off the band. So that will be 1 repetition is when they come all the way down to full range, and then they're able to lift themselves off that band. And that will be set to a metronome of 60 beats per minute as well. So we do hold them accountable to 30 with that. But this is actually going to be up for a discussion with our team, just because looking historically at our data, we're not really getting our boys near that. Most our backs will be sitting around 25. Most our forwards will be sitting around 20, just on average. So that's a little homework task I've got at the moment, is going back through historically what our data has been and just seeing, are these metrics actually realistic for us as a club, and maybe again chatting to some other clubs and seeing what they do from a calf capacity point of view.
Yeah.
So that will be our calf testing. Then we'll look at our adductor squeeze scores as well. So we'll get them on the force frame as well. So we'll get them straight leg, 0 degrees. We'll do an abduction and abduction to see if we can get a ratio of that as well. We'll then get them at 45 degrees, just abduction, so ABduction, no, ADduction, adduction, and then at 90 adduction as well. So different positions just assess different components of your adductors. And I think the research on that at the moment is saying that the bent knee position, so the 45-degree position, is the most optimal position to assess adductor function, but the straight leg and the 90-90 is more assessing the ability of the body to transfer loads across the pelvis. So that's my take of it anyway. So we'll do that for our groins, and we're also going to this season look at isometric Copenhagen. So having their heel on a bed, side lying, basically lifting up and seeing if they can hold that position for 30 seconds. So I haven't been able to find any research on that, but we have identified that we have really lacked some of our capacity testing of our adductors. And well, why are we not doing it? We've shown this year that we've got a lot more hip and groin pathologies, and there's players in the gym that are saying to us, oh, I actually can't hold that position because that's quite sore. So I've just always done a bent knee. Okay, cool. So like, why don't we just build you up to be able to do it straight leg? Because there's a lot of research saying that Copenhagen's are quite effective for adductor injury prevention. So that will be part of our adductor testing this season. We'll have a look at our shoulder internal and external rotation as well. So we'll basically get them supine with their wrist in the force frame and making sure that when they internally rotate, they're not adducting too much, because obviously it's a bit of a power trip. Boys just want to show you how strong they are. So making sure that the movement, you're not going to be able to isolate internal rotation completely, but just making sure they don't physically just adduct all the way in. So we'll put that elbow. So on the VALD website, there's actually, it shows you all the setups of these tests. So that's something that I would recommend you guys to look into. But if you rest your elbow in, I don't actually know what it's called. I've just called it an elbow gutter, but it's basically a pad that keeps them out of extension and also helps them to be able to isolate the movement a little bit better. So do internal and external rotation there. And then we're also doing, sorry, I'm getting excited, the ASH test as well. So if you guys have read about the ASH test, that's probably, okay. So the ASH test is quite a rugby specific test as well. So what you do is you have them prone with one arm overhead. So that's your eye position. So you get them doing a maximal force production there. And there's different ways to do it. So you can either do it pushing, yes. Yeah, so your wrist will be on the force plate, basically, and then the other hand will be beside your body, and it'll be, so you're looking at rate of force development. So you get them to push hard and fast, basically, in the I position. Then you get a Y position, so slightly out to the sides, and then a T position, so at 90 degrees, looking at your left and right there. So then we're looking at basically, the ability to be able to transfer loads through the shoulder joint, and then you're looking at your cuff strength with those two shoulder tests that we're doing. We're not looking into any sort of plyometric push-ups or anything. I know some clubs have probably touched on that in the past, but it's not something that we find that would be valuable for us. And that's probably purely because we don't really have that many shoulder injuries, which is quite bizarre, because you think rugby union should come with a lot of massive shoulder injuries, like, you know, they're big tackles, there's like quite a lot of load that goes through the shoulders, but we typically don't really see that much of them. We'll get niggles, we'll get stuff where they've got a lot of internal impingement, they want to get massive, they're doing a lot of push and not doing enough pull. We have stuff, occasionally we'll get like a massive pec tear as well, and that'll be typically where they're in a position where they've got their arm outstretched and someone will run through them in a tackle, and they'll rupture their pec in that sort of sense. So I think I've seen 3 of those since I've been at the club. AC joints, massive. We do get a lot of AC joints actually, but a lot of them will be able to function. We don't really inject them as much as what we do in Australia. So that's probably another different thing coming over here versus back in Australia. I think back in Australia, we're quite happy to inject AC joints, sternums, ribs, all that kind of stuff. But here we typically don't do as much of that. And I'm not sure why. But yeah, we try to let them heal naturally and rehabilitate them well rather than kind of pushing them on. So yeah, AC joints and sort of cruddy sort of labral issues and impingement are probably the 3 things that we would see with our shoulders. But yeah, so in summary, probably not getting enough shoulder injuries to warrant investigating any more shoulder testing as part of our profiling. And then we're also looking into some neck testing. So Leslie McBride is a physiotherapist over here who's done quite a lot of research on some of the peak force tests of our necks. So it's quite an interesting setup. So the force frame where it's come to us, the first season, it was just a normal size force frame. So getting players on their hands and knees and setting them up in that position where we'll do a peak force extension, peak force flexion, peak force side flexion each side. It would work for anyone that was under 6 foot, which is a massive issue given that our locks are 6'4", 6'5", huge boys. Yeah. So we were kind of at a bit of a loss with this because we weren't getting them in the best position to be able to provide their force, and then they were just getting a bit grumpy. So we did it anyway, just for our interest to see what sort of numbers we were getting. But this year, what we've done is we've actually ordered a higher frame, so it's like an add-on. So we'll actually be able to get them into more of a neutral spine position. We've also a little bit of a difference from the VALD protocols that we've got set up. So the VALD protocols has them when they're flexing and extending with their hands under their chest. Our boys' shoulders are so big that they can't really comfortably get into that position. So our backs might be able to, but some of our forwards won't be able to. So we're actually just going to get them in 4-point with wrists underneath their shoulders and place some mats around the frame to just make it a bit bigger so they've got a flatter surface to work from. We'll also take our tight 5. So they're the first 5 in the scrum. So our 3 big props and then our 2 locks. We'll take them through this thing called the Don Gatherer test, and that's similar to a peak force test in the isometric force frame. Although the difference being that in the force frame it's a maximal voluntary contraction, whereas on the Don Gatherer we'll actually do a break force test with them. So we'll basically get them seated on a chair. They'll hold on to like the plinth in front of them with their hands, and then we'll basically place a harness on their head. And then a physiotherapist, not me because I'm not strong enough, but one of the male physiotherapists will basically gradually apply force to try to break them. So they hate it because it feels like we're going to snap their neck. So basically, harnesses on, we'll gently pull, and then we'll pull as hard as we possibly can until they can't physically hold that, and then they'll end up breaking. So that to us is a true measure of force because we've exceeded their ability to maintain that contraction. And there's a bit more research on that at the moment compared to the force frame stuff that's coming out. So Leslie's force frame stuff with the normative data is not getting released till later this year, I believe, or hopefully soon. And she's looked at a lot of the premiership players and just the difference of their strength across different positions. And then we're going to hopefully be able to reciprocate some of her data and being able to compare our athletes to what her athletes were showing. And then hopefully we can use that as part of our baseline for our profiling. Yeah, if that makes sense. So that's pretty much in summary of, so we don't actually, I know it's really surprising, but we don't really get that many neck injuries. We get a lot of stiff necks, particularly after a game that the boys would be sore, but in terms of massive disc injuries to the neck, they're not as common as what you would expect. And I think that's probably because they get developed through such a young age as well. And we also have stuff in our programs for our necks as well to maintain some of their strength. So yeah, that's it with the necks. What else? I think that is the summary of what we'll do with our profiling. So we tick off our calf testing, hamstring testing, our shoulder testing, neck testing, groin, and we'll also look at some jump testing as well. So we'll look at our counter movement jumps, looking at like rate of force development, their landing forces, asymmetries. We're also going to have a look at a single leg counter movement jump and a drop jump as well. So I think my boss this year also wants to film it. So this is something we haven't historically done. I think he wants to have a little bit of a look at some of the angles that the players are getting themselves into. I'm not sure if that's maybe to do with some of because we've had high incidence of groins this year or what it is, but it's something that maybe we can have a bit of a play with. So it'd be interesting to get the data from this. So that's all our profiling. So basically from our profiling, what we'll do is we'll compile a bit of a report. And then we'll sit down with our strength and conditioning team and we'll say to them, look, this is what we've identified. These are the athletes at risk. Kara's going to program the groins and the backs. Jamie's going to profile the necks and the ankles or knees or whatever it is, the ankles and what's the other one? Shoulders. And then we'll kind of delegate. So each physio will kind of have a different responsibility of putting the extras in their team builder programs. And I think the best way to do it, so what we've been doing at the moment is just tacking it onto the end of their gym sessions or tacking it onto the start of the gym sessions. But I think the buy-in's actually going to be a lot better if we can superset them with what they're doing in the gym. Yeah. So for example, they're doing their heavy leg day, they've got a squat, they can superset that with some peak force neck stuff. That's not going to that's not going to affect what they're doing from a squat point of view, rather than sitting there chatting and not being productive, which happens a lot. And there's an element of that that's quite good for team camaraderie, but we could definitely be a little bit more efficient when it comes to some of our injury prevention stuff in the gym.
Yeah. Do you have a interesting or rare case study that we could walk through?
Yeah, we can do that. Let's go through the T-Junction. Since we seem to be speaking a lot about the T-Junction, why don't we go back and have a bit of a look into that? So we could talk about, so he's a young academy player who's come back from an ACL reconstruction in 2020. So he was unfortunately ruptured his ACL right before lockdown. Lockdown over here was obviously a massive thing, as it was in Melbourne, Australia, and Australia in general. So basically, he came into the clinic the next day saying, I've done something really bad to my hamstring. And this player is typically one of those ones that you're like, oh, yeah, right. Like, let's see. Like, I'm sure you're fine. Let's have a look. So I had a bit of a look. And the thing that just wasn't really adding up to me is that he was tender sort of from mid-belly, sort of like lateral side of the hamstrings, all the way down. I could track it all the way down to its attachment on the fibular head. Right. I find that quite unusual. It doesn't normally extend that far if you've just had a bit of a hamstring injury. there was also quite a lot of fluid that was kind of pooling around like his posterior lateral knee as well. So I was like, oh, that's quite weird. So you don't, with a low grade, it's very rare that you would see quite a massive amount of fluid sitting around there. So I just thought it was a bit bizarre. He'd lost about 20 degrees of range of motion on MH fake and passive straight leg raise, but obviously wasn't really, I was just taking him to kind of pain one. I wasn't taking him in range. And in terms of some of these isometric tests, he just didn't really want to produce any force. So had him doing some isometric 30-30, like position 90-90, and he was just like, no, can't do that, no, don't want to do that, no, that's really sore. Cool. Let's give it another day to settle. So that was, I'd seen him on Sunday, came back in on Monday, still not really that much better. So my boss had kind of pulled me inside and been like, what do you think it is? I was like, I can't tell whether he's being a little bit soft or if it's really, really bad, but I think we do need to scan it. So we ended up scanning him, and it came back with a 3C of his long head of biceps and a 2C of his short head of biceps with some damage to the the T-junction. So we had a bit of a think about this because this guy, prior to this injury, had a hamstring. I think he had a couple of hamstring injuries. This might have been his third hamstring injury in the last like 6 months or something like that. So I hadn't worked too much with him in the past. He'd been in our academy program. So he'd come up. So just getting a bit of history on that. And then we thought, okay, so this is quite a significant injury. This is somebody that has come off the back of quite a number of hamstring injuries around a similar area. Let's just get a surgical review. So we sent him down to Professor Haddad in London. So he does quite a lot of our soft tissue repairs. And he basically looked at it, thought he could feel the junction between the long and the short head of the biceps, thought it was something that could be surgically repaired and would be beneficial to be surgically repaired. So we ended up doing that. So what they did was basically, it's actually a really simple procedure. And on the paper that he's actually put out, you can actually see the image of what they do. So there's 4 different slides, not this particular athlete's hamstring, but you kind of can see the gap in the junction. And then all they do is debride it and then stitch it back together and then close it. So it's really simple. You get about a 10 centimeter scar over your lateral hamstring, distal lateral hamstring, and that's pretty much it. So it's pretty good. It's a pretty easy procedure. Pain wise is pretty well managed as well. So he was sent back to us in a brace. So I'm turn my laptop on so I can double check the markers. So he was braced at 60-90 for the first 2 weeks. After those 2 weeks, so that was the acute phase. So obviously what we're trying to do in the acute phase is we want to decrease the risk of DVT, particularly postoperatively. A lot of ankle pump sort of stuff as well. He was able to start some, again, coming back from ACL stuff, we would need to make sure that his VMO was good and active as well. So we did a lot of quad activation stuff. We did a lot of just like ankle pump stuff. We did a lot of just glute bridges, sideline hip stuff, a little bit of low level trunk, everything kind of working away from his hamstring. After the 2 weeks, he was also on crutches, partially weight bearing at this stage. So locked at 60-90. After that, he was, I believe it was, let me just get it up. I think it was 30-90. Week 3, he was 30-90 degrees, still partially weight bearing on crutches. And then week 4, he was full range of motion, still in his brace. Week 5, he could come out of his brace. Okay. So basically, from that sort of, that early phase of rehab, it's going to be that sort of wound and pain management, decreasing risk of DVT, working on structures around the hips and trunks and all of that. Once he was able to stretch his brace out a little bit. So I think it was week 3 we started to use the complex as well. So the reason we didn't use it earlier is we didn't really want too much activity kind of around that scar healing. We really wanted the wound to be good. If your wound doesn't get infected, it just sets you back a week or 2. So it's just not really ideal. So we're really, really, really careful in those first 2 weeks. We don't really do anything, to be honest. So then week 3, we were using complex. We started to introduce some isometrics within the range that we had available. So again, he was locked at 30-90. So he was doing some sort of prone hamstring work with the bands. We did a lot of sort of not so much gait re-education until week 4, but once we got to that week 4, that's when we started to introduce some sort of pool-based gait re-education stuff, some land-based gait re-education stuff, and making sure that he could regain that extension as well. Because if you think you've been locked in a brace for 3 weeks, your knee does get quite stiff. Historically, his knee does get stiff because of the ACL surgery. So we were doing a lot of patella mobilizations. And then once he was full range of motion out of the brace, we were doing some tib-fem mobilizations as well. And that's been an ongoing thing throughout his rehab as well, is making sure that knee joint is solid. In regards to some of the treatment stuff as well, in regards to the manual therapy, I would also introduce, because the biceps femoris has a rotational component, I'd also reintroduce some sort of rotational based tib-fem mobs as well. So that was that. And then we went into, got my 2 laptops going, his sort of early dating phase. So early learning stuff. So he had his full range of motion. So this is more sort of our capacity sort of phase as well. So we're still probably week 5 and 6 working a bit more on his proximal loading stuff. So he did a lot of glute bridges. He introduced squat patterns around here as well. So it was quite good. We could start to introduce some sort of prone capacity stuff. So sort of reps of like 15, 20 just banded hamstring curls. We also started to look at some of his sort of like prowler and sled walks, so just really, really light, but just getting a little bit of horizontal force as well. And we started to introduce some sort of prep for his jumps. So we did stuff like force absorption. So part of his load acceptance phase, instead of being able to produce that plyometric force, we did a lot of force absorption stuff. So like coming up on 2 toes and then dropping down on his heels, coming up on 2 toes, dropping down on one leg, stepping up a box, being able to absorb that force. So that's a really crucial in the first sort of early stages. So that was that sort of week 5, 6. Once we're kind of comfortable with that, the diagnostic criteria that we would use for him is we wanted him to have full hip range of motion, full ankle range of motion, full hamstring range of motion in regards to his passive straight leg raise and his MHFA, and to have a good sit and reach as well. And the reason that we added all of that is that was some of the post-op criteria that the surgeon had put on his protocol. So basically wanted him to regain full range of motion in those joints prior to progressing. Yeah. So we focused on a bit of that. We also then had a look at, we used the force frame to have a look at his maximal voluntary contraction at prone 30-30 and sort of supine sort of 90-90 sort of position, and just to see where his strength was. And he actually is quite impressive. He pretty much regained his full strength like within like 6 weeks like of that particular test. We also then had a look at his calf capacity stuff here as well. So obviously we'll make sure that he's functionally in a good position to be able to start to reintroduce some of his running stuff the following week.
Yeah.
So yeah, so it's quite interesting. So I know it's quite wordy. I'm so sorry.
No. That was fantastic, because what that outlined or showed me was, even in complex like cases, your structure is still basically the same.
Yeah, absolutely. Absolutely. So it gets a little bit more tricky towards the end, but I think as long as you have your processes in place and you have a really solid treatment planner. So we actually put together a planner, and each week you can see, okay, these are my goals of this week. These are the diagnostics he needs to tick off before he progresses to the next phase of his rehabilitation. These are the days he's going to do his key lifts. These are the accessory things that we need to work on. For him, it was some hip stuff, and he's like sort of knee stuff as well with his history. And then that way it kind of holds you accountable as well. So you don't get 8 weeks down the track and be like, oh crap, like, why is he not strong? What have I done? Oh wait, he started to run, but I actually haven't done any horizontal loading yet. Yeah. So it's a way to kind of sit down, and it is tricky because you can sit down and plan out a planner, and then sometimes things don't go to plan and you have to, okay, crap, now I need another week. And then obviously with the pressures of professional sport, you'll have people being like, your boss coming up to you being like, can we get him back any earlier? Why has he not done this yet? And so you then need to go back to your planner and be like, oh, is it possible for me to get him back earlier? That would mean that we need to be doing greater than 90% velocity a week earlier, which would mean before that, we need to be ticking off 80% velocity. Before he does that, we need to tick off all his diagnostics to make sure he's safe to be able to, like, so it's like a working process sort of a thing. If you don't have a plan and someone comes to you with that, you're like, I don't know, I'm just going to see what he does tomorrow and see if he's good. Like, you need to, particularly at this level, because if something goes wrong, you've got to have your data there and your planner there to be like, you know what, this went wrong because I didn't do this, or this went wrong. We've done everything we actually could have done. I think this is just one of those things. So so that's a really important phase. So that's kind of our week 5, 6. So week 7, 9, so it's the same sort of stuff, but you're then kind of progressing some of your, so I think this is where we started to introduce our eccentric stuff. So the eccentric stuff we started with was more proximal loading again. So doing some sort of double leg, like hamstring bridge, single leg lower, and then going into, once it was safe to do that, we'd start with some sort of band assisted Nordics and then kind of progress him through range there. We just progressed some of our trunk stuff as well, because again, the research was saying that ipsilateral trunk flexion, side flexion can impact or can make your risk of injury higher. So we just try to tick off all our bases. So how do we get him strong? What other things do we need to be considering? His balance was pretty pish as well. So we did a lot of balance stuff as well. And then just took him through some more diagnostics. So took him through all his peak force measures. So his seated plantar flexion, standing plantar flexion, long lever bridge. We took him through some capacity stuff with his hamstring bridge as well. So he had to get 30 single leg hamstring bridges left and right. I think there was research about hamstring injuries with the AFL years ago saying that being able to do 30 single leg bridges decreases your risk of hamstring capacity. Now, we don't actually include that with our profiling because all our guys can actually do that very easily. but yeah, that's something that we still include as part of our hamstring rehabilitation, particularly some of these longer ones. And then we look to use jump diagnostics. So his counter movement jump, single leg counter movement jump, jumped up, all of that. So making sure that basically we get him as strong as we possibly can. We safely introduce different rehab bits and bobs. So starting proximal and then going into our distal stuff, and then just progressing some of our running loads, depending how we go. So straight line stuff, then we start to introduce some sort of weave based patterns. Then we start to introduce some sort of side shuffling patterns, then some cutting patterns, and then our rotational patterns. And then it's our controlled reactive drills into our uncontrolled reactive drills, into our skill specific, into our contact. So there's quite a lot of things that you go, okay, before he does this, he needs to tick this. Before he does this, he needs to tick this. So again, just following your processes.
Yeah.
I think the hurdle that we got to is that he ticked everything off pretty quickly, except for his biodex. So a biodex is basically, so his Nordic and his biodex. So his biodex is like a I'm not sure if you guys have seen it. It's like a maximal force knee extension and flexion. So it's a machine that you actually sit on, and it is absolute death. So it's like it looks like a seated leg extension, and you sit on it and you apply a maximal knee extension force and then a maximal knee flexion force, and you get peak force, like true peak force measures, and you can also get capacity measures as that. So he'll do a rep of 15 each side, and he'll also do a reps of 5. So we start with his 5s, but we really struggled to get those markers within the numbers that we were quite happy with. So his Nordic was quite slow to come back with. So we basically found a correlation between his Nordic strength improving and his biodex scores. So we decided that we weren't going to biodex him again until his Nordic was in within 90%, because it kept fluctuating. He'd fluctuate between 80 and 85. And at this stage, he was kind of at like, it was at like, I think we planned for him to be back in 4 months, and it was now 4.5 months. We're like, oh, what the hell is going on? Why is this not coming back? So we just targeted him with some sort of like single leg Nordics. We did some sort of band resisted and focus on time under tension. We gave him some plates to hold on to as well, and we just targeted really heavy. We used this thing called the flywheel, which is like a maximal eccentric. So it's a really crap cable thing, basically, that you put on your heel or put on your shoulder, wherever you want. And so you help them to do the concentric movement. And then as you let them go, they have to fight the eccentric. They have to fight the leg moving, basically. So it's a really, really heavy eccentric exercise. Brutal. So they were the two things that we focused on him. And he was doing them a couple of times a week. And eventually he was able to pass the biodex scores, which was good, but that was his thing holding him back. So he'd done everything we'd asked him to do. It's just he wasn't allowed to run greater than 90% velocity until he ticked off these last 2 markers, which meant we weren't happy for him to be able to be exposed to reactive elements of training until he was able to be able to hit these markers as well. So that we were kind of in a bit of a no man's land, just waiting for him to get stronger before we could progress him. So something that we thought was going to be 4 months. So we added on to the research was saying that it should be 3 months, because as an academy athlete coming back from ACL, we increased it to 4 months so that we could work on some of our accessory stuff. Got to 4 months and he still wasn't where we wanted him to be. So I think it took us about like 5.5 months. So it was a really, really long process, and it was really infuriating because it took us about a month just trying to chase these numbers before we could let him progress. So yeah, that was a challenge. But now he's back. He played his first game last weekend actually, and he's doing really well. Yeah, so it was a challenging rehab, but also quite rewarding at the end.
Yeah, that's like a perfect segue into this next question I wanted to ask. Is kind of just my understanding of rehab in general. I feel like it's a bit patchy, but basically one question I had was, what happens? You've got these exit criterias between phases, but if one thing is not being met, like, is there a leeway to just move them on to the next thing while hoping that the deficient marker is going to catch up? Or is it like a solid no, like we can't progress until everything is where it should be?
I think it depends on the marker. So obviously hamstring peak force and eccentric strength and stuff is something that's really, really important when you expose them to greater than 90% velocity. But stuff like, we were holding boys accountable to single leg calf raise of 30. So this athlete didn't necessarily hit 30 first go, but we weren't going, like, that was part of his exit criteria to be able to return to run. He got around 25, I think, and that was the same as his baseline. So in profiling, he established that 25 was his normal, but our exit criteria is still 30. So even though he hadn't passed that, we were like, you know what, he's kind of back to what he normally would be anyway. Like, I'm comfortable with him to progress. Some of our trunk capacity stuff as well. So we hold the boys accountable to 2-minute planks and 2-minute side planks. He wasn't hitting 2-minute side planks, hitting about 90 seconds. So looking at that, being like, oh, you know what, that's not going to hold you specifically back from progressing your running. But why don't we target that exercise in some of your gym programs? So I think in summary, it depends. Like, if it's a calf marker that's down and you're rehabilitating a calf, then yes, it's important that they hit that before they progress. If it's a hamstring marker and they're not hitting the hamstring markers, then yes, it's important they hit it. There are interesting situations where sometimes they are not hitting these markers, and it becomes a collective discussion. So one of our really senior players had come back from a proximal hamstring reattachment, and he was really, really struggling to get his Nordic scores back. And we were trying for months and months and months to get these scores back. He was passing everything. He'd returned to like elements of training. Like this was just this one thing that he wasn't ticking off. And we basically collectively sat down and had a discussion being like, well, some days he's hitting it, but like 90% of the days he's not hitting it. Like, are we happy and comfortable? And we said, well, if he can hit his long lever bridge force and peak force, and he can prove to us that he's back doing his same lifts that he's doing in the gym with the same like amount of weight that he's been lifting prior to injury, then we're comfortable for him to return to rugby and to be exposed to high speed, even though the Nordic hadn't been perfect. So there are situations that you'll come across where you look at the athlete at hand, you look at the data, the other tests, like what other things could we be doing for him to prove to us that he's capable of being able to do this? And then it becomes a wider discussion of, okay, yep, like we're happy, like let's push on, or you know what, no, let's get some other people involved. Let's target this a little bit more. Let's spend another month. So, and it depends on the time of season, the player, the injury, all that kind of stuff. But it's definitely something that with experience, you get better at being able to identify and filter through different elements of the rehab and what's super important and what you can change and modify and be comfortable with, I suppose.
Yeah, that makes sense.
Yeah.
All right,
it's not.
Yeah.
It gets better. Trust me, as you get more experience and you get to know the people, know the tests, know your processes, it does become easier being a physio. But those first few years, when I think it genuinely takes about 5 years as a physio to figure out what you're doing, once you get past that, and it's okay.
Yeah. So I appreciate that, and like you taking the time today to explain everything in so much detail. That was amazing.
No problem. I hope you got something from it, and I've really enjoyed the chat. So thank you very much for having me on board.
Thank you. So before we head out of here, I have one more question for you. And
okay.
It's, if you had one person who you could refer onto the podcast, who would it be? But you would have to help me get in touch with this person.
Okay. I would like to nominate, I haven't actually spoken to him a bit, so he's probably going to kill me. Ibrahim Karim. So Ib was a friend of mine who we went to university together, and we were both involved in the H&A new graduate program scheme together. So he actually went down the football pathway. He did some stuff with the Sydney FC for quite a number of years. And then I went down, obviously, the rugby pathway. And he's now actually over here in the UK as well. And he's working with Manchester United. So I believe he's looking after some of the women's stuff and dabbles in a little bit of the men's stuff. But he'd be quite interesting to talk to because he is someone that specializes a little bit more in rehab. So whereas I do more of the injury prevention bits and bobs and profiling and daily management of guys in the travel, he does a lot more of the rehabilitation side of things in professional sport. So it'd be really, really interesting to get his take on what it's like to work in professional sport. I also think they have the list. They don't have 65 athletes. I think they've only got like 20 or 25 on their list. So it'd be interesting to hear how he manages with that.
Yeah, absolutely. What was his name again? I didn't catch that.
Ibrahim Karim.
Ibrahim Karim.
That's awesome. I will shoot you his details after this. So
yeah, awesome. Okay, well, Cara, thank you again so much for your time. It's been a blast. I learned so much from you. I can't wait to go back through this episode and just pick up these little tad bits that I missed.
Sorry for all the filtering you're going to have to do.
No. That was perfect. Good luck with the game today. Enjoy the beautiful sun.
Thank you. I'm going to go for a walk, actually. We'll chat to you later. All the best.
Yeah. Thanks, Cara. All right. Bye.